Hi everyone, my name's Naveen. I'm one of the Nephrology and Critical Care Fellows, and I wanted to start this series on nephrology in the intensive care unit and important topics that an ICU doctor should be aware of. The first topic that I wanted to talk about was CRRT, and in order to understand principles of CRRT and what are things that we should know CRT can do and cannot do, we actually have to understand what CRT is trying to achieve, and that's clearance. This topic of clearance is something that we've all probably discussed, but maybe not necessarily understood. And clearance is the solute completely removed from a volume over a period of time. And this is critical. This is critical because it's what we try and achieve with any sort of clearance, whether it's intrinsic renal function versus one of our modalities of renal replacement therapy. And the way we calculate clearance can be for any single solute, and it will be different based on the different volumes that we're clearing from. And so, for example, the equation that we are probably most familiar with for clearance is UV over P, where this is referring to the concentration of some solute in the fluid of choice. Let's use urine as our classic one, and then the concentration in our plasma times the volume over a period of time that is removed, and that could be the 24-hour urine output, for example. And the traditional clearance that we think about is creatinine clearance, and if you all remember the units of creatinine clearance, it's mLs per minute, right? So again, a volume over a period of time. However, with CRT, of course, we're not using urine. And so I want us to keep this idea of clearance in the back of our minds, because we're going to talk about how we actually get clearance from CRT and what it is, what factors we're actually controlling in order to try and get clearance. So I'm going to erase this board, and then we're going to instead look at uh, the types of clearance that we can achieve with CRRT. So there's actually four main types of clearance. And clearance of a molecule is going to depend on certain factors of the molecule. So first, let's talk about the four types of clearance, and then we'll talk about what factors influence how uh, 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 a molecule is removed. So the first type of clearance is diffusive clearance. Okay. Now, if we think about a fluid space with a filter in between, such as our dialysis circuit, where blood is going through one side, and then on the other side is our dialysate fluid or some other fluid that could be, that could be any sort of Calvin current or parallel current fluid. And then if we think about the molecules that are on one side that are not in the dialysate fluid, right? There's a concentration gradient where there is more on one side than the other side, and the concentration gradient leads to a movement of the fluid to the less concentrated side. This is called diffusive clearance. So the molecule itself is moving from a high concentration gradient to a low concentration gradient. Okay, but this is only one type of clearance that we see with CRT. It's probably the one that we make use of most, but it's only one type. Now there's three more. The next one is probably the next important one, and that's the idea of convective clearance. But I'm going to pair it with ultrafiltrate just so that we talk about both of these at the same time. So in this idea, sorry for my drawing, it's not very good. Again, we have the blood space and dialysate space, and we have all these molecules sort of sitting around in the blood space and not in the dialysate space. Now, one other thing that we frequently do is remove volume from a patient. And so what we do is we apply a transmembrane pressure that pushes fluid across this semi-permeable membrane. And as it does this, so water moves to this side, or serum rather is probably the best way of saying it, rather than just water, but serum moves to this side. And as it moves to this side, there are molecules in that serum that are just dragged along with the serum. Okay, so just molecules are dragged with the serum onto the other side. This is called convective clearance. So the movement of serum across using the transmembrane pressure is ultrafiltrate, but the actual removal of molecules that are forced to travel with that serum as it moves across that semipermeable membrane is called convective clearance. So it's not necessarily going across the concentration gradient like diffusive clearance. And I'll say it is a lot slower for certain types of molecules that we'll talk about in a second than diffusive clearance. And the fourth type of clearance is one that we don't really care about that much, and that type of clearance is called adhesive clearance. So this is the idea that with our filter, we had molecules that we thought would get stuck to the filter, and then when we just took out the filter, those molecules would be removed with the filter. It would be adhesed to the filter, and so we call that adhesive clearance. This is a type of clearance that we now recognize is probably not that important, but it's a type of clearance that actually at some point was considered the most important type of clearance before we really recognized that it wasn't. So I'm going to quickly remove these because I want to talk about how these types of clearances are affected by certain characteristics of molecules. So when we talk about molecules, there's really two things that we care about. Regarding the molecule characteristics, and the first one is size, and the second one is charge. So you'll probably remember from your biochemistry that depending on the type of membrane in between two spaces, such as a cell membrane, for example, molecules can move in, and characteristics of that membrane, molecules can move in and out of that membrane, sometimes freely or sometimes very restricted, and sometimes requiring active transport through a transporter. And this was dependent on size and charge largely. So size is the most important thing. So the smaller a molecule, the better it moves across a membrane. And the larger a molecule, the slower it's going to move across a membrane. This is just because of physics, right? Charge, on the other hand, also matters. So uncharged molecules move better versus versus molecules that are charged molecules across the cell membrane. You might remember that across our lipid membranes, for example, charged molecules were more likely to stay compartmentalized in the space and had to be moved by a transporter, for example. However, this is sort of overcome by the fact that if they're really, really small molecules, even if they're charged, they freely move across the membrane. So why does this matter to us? Well, traditionally, when we think about clearance or removal of certain things, yeah, we talk about creatinine, but we also talk about urea. Now, urea is not a uremic toxin, but it is a small, uncharged molecule that very easily is removed by the filters within our body or filters of renal replacement therapy. Because it's a small uncharged molecule, it moves very quickly across the membrane to equilibrate its concentration gradients. On the flip side, the other ones that we usually care about is potassium, which is a small charged molecule. It turns out because it is small, that outweighs its charge status, and it also very, very easily moves across a membrane. Okay, so that's really important for us to understand. On the flip side, a molecule that does not move so easily, as easily, is going to be something like our myoglobulin. So myoglobulin is a very large molecule, and so myoglobulin is going to get stuck on one side of the membrane rather than just diffusing quickly across. And depending on how easily a molecule moves across the membrane, we have a term for it that's called the sieving coefficient. So sieving coefficient is referring to the concentration of something in the effluent or the urine or whatnot versus the plasma. Um, and this is the idea that the more that moves across, the more permeable it is across that membrane. And so, for example, if I have a sieving coefficient of 1, that means it very easily moves across the membrane because 100% of, say, urea is in the effluent versus that matches the urea that's in the plasma if they're the same. Whereas a sieving coefficient of 0 means that none of it moves across the membrane. And so molecules that are really easily moved by dialysis are ones that have a sieving coefficient of 1, but molecules that don't have the sieving coefficient are going to need other tricks, or perhaps dialysis is not the way to go. So I think for now, I've introduced a few really important topics, and that is what are the types of clearance, modalities of clearance. We're going to really pay attention to diffusive, convective, and ultrafiltrate. And then I've also talked about this idea of molecules moving based on charge and size. Okay, now this actually takes us to what is CRRT, and I think from here we can apply quite a few of our principles we've just been focusing on now. So what is CRRT? CRRT comes in multiple types, as all this means is continuous renal replacement therapy. And it turns out we have a lot of modalities for continuous renal replacement therapy. The few that we think about are CVVHD, CVVHF, and then CVVHDF. What are these? One is continuous venous-venous hemodialysis. The other one's continuous venous-venous hemofiltration. And then the final one is continuous venous-venous hemodialofiltration. This is the one that we do primarily at our institution, but it incorporates these two. It's essentially a combined version of those two. And so we can talk about all the principles by understanding CVVHDF, and I'll try and separate it out so we have an understanding of what are all these achieving. But what I will say for now to start is method 1 is primarily diffusive clearance. Method 2 is primarily convective clearance. And then method 3 is a combination of both diffusive and convective clearance. Okay? All right, so let's draw out CRRT that we traditionally think about, and we'll start talking about crucial portions of CRT. So I'm going to draw a person, and usually the catheter, let's say the catheter is here, and then from that catheter, we have our circuit. Just going to widen out the circuit a little bit. And just drawing this out, and this is the return to the patient. Okay, so let's assume that we have our blood space. So blood is coming out this direction, and then it's returning back to the patient over here. And so as blood moves across the filter, there is a few options that we have. So when we do hemodialofiltration, we have, sorry, give me a second to change my color. When we do hemodialofiltration, what we do is a combination of both convective and diffusive clearance, and we start with this idea that we have a dialysate fluid that is moving in a counter current direction to the blood flow in the filter. So this is the machine, the blood is entering the machine. Here is the filter in the machine, and blood moves in one direction. And this is not a rule. You can actually swap it so the dialysate is going in any direction you want, but traditionally we have the dialysate moving in a counter current direction. Why does that matter? So the idea is that we are constantly supplying blood that has the molecule that we want removed from the body, whether that is potassium, urea, uremic toxins, molecule of ingestion, alcohol, whatever it is, there's ammonia, there's a molecule that we're trying to remove. So we constantly supply fresh blood that is fully concentrated with that molecule. Then we supply a dialysate of our choice. This dialysate can be made, there are many different people or groups that make different dialysate. They have different concentrations, but traditionally speaking, these are something similar to a balanced crystalloid where they have but not necessarily quite a balanced crystalloid, but you have like a sodium, maybe say like 140 or 132 or something like that, depending on what you're choosing. And then you have a K that is variable. This is something that we can choose based on how much potassium we're trying to remove in the gradient that we want to create. It's going to have a calcium that we care about, between usually 2.5 and 3.5 milliequivalents per liter. Um, uh, and then yeah, I think that's a pretty good start for the dialysate fluid. I guess, and bicarbonate is also really important too. It's usually 22 to 32 millimoles per liter, or milliequivalents per liter in the case of bicarbonate. Um, and we sort of go from there. So by creating this countercurrent flow, though, the dialysate is coming in with a concentration that is 0 of, say, the uremic toxin that we want removed or the ammonia that we want removed, but not necessarily 0 of everything. For example, if I have a patient whose K is 7.2, 7.2, and then the dialysate creatinine K is 4, well, then there's a gradient between 7.2 and 4 that I'm trying to push potassium to until it equilibrates. On the flip side, though, I could use a lower K. I could use a K of 2 or a K of even 0, for example, and just that would change how fast I'm removing K from the body. And we'll talk about that in a second. But essentially what I'm trying to say is that the dialysis actually creates a gradient between the concentration in the blood versus the dialysate that allows fluid removal of the solute. And we'll get into what clearance is in a second. So let's specify a little bit more. What is hemodialofiltration, though? Sorry about this. So blood going in one direction. And so in a continuous venous hemofiltration, as opposed to hemodialysis, we have what's called a pre-filter and a post-filter fluid as well. What is this? So in the pre-filter, we take blood that's moving across the circuit and then we insert a fluid of our choice into the circuit before it actually gets to the filter. And then we also insert a fluid of our choice as the blood is exiting the filter to go back to the body. Okay, this fluid is generally the same as a dialysate fluid. We often use the same exact fluid because, again, it's essentially a balanced crystalloid. So, for example, I may be adding a fluid that has a sodium of 140, a K of 4, and a urea of 0. And I'm diluting the blood here in the pre-filter space. And then on the post-filter space, I'm also administering that same exact fluid back to the patient. But again, it's clear of urea. It's going to dilute what urea is left. But in return, if all I did was give fluid pre-filter and post-filter to the patient, then they would become plump very, very quickly because it's essentially just giving them IV fluids at that point. So the dialysis machine knows that when you set these fluid rates up as a pre-filter fluid of X and a post-filter fluid of Y, then it removes X plus Y automatically from the blood using a transmembrane pressure. So if we remember from our clearance, this is the idea of using convective clearance. And so if I have a rate of 300 pre-filter mLs per hour and a rate of 200 mLs per hour post-filter, well then x plus y is going to equal a removal of 500 mLs per hour. And so this is actually ultrafiltrate that the machine is automatically doing in order to make sure the patient remains net even. But what am I doing? I'm removing fluid that is completely a serum that is saturated with the urea, and instead I'm returning fluid that is of my choice. I'm essentially, think of it as replacing their blood with fluid of my choice. And so this is one way of achieving clearance, because I'm removing serum that has a certain amount of stuff and putting in fluid of my choice that is lacking that solute that I wanted removed out of their body. Okay. Now, hemodialofiltration is when we do all three of these at the same time. So not only am I putting a fluid, pre-filter, post-filter fluid, but I'm also using this dialysate fluid. I should have said that hemodialofiltration. Sorry, sorry about that. So hemofiltration is not including this countercurrent dialysate fluid. So hemofiltration is only the pre-filter and the post-filter without a countercurrent dialysate flow. But the moment we add this countercurrent dialysate flow with the pre-filter and post-filter, we are achieving what's called continuous venous hemodialofiltration. So we're doing both. So not only are we getting the benefit of diffusive clearance by creating a gradient, we're also getting the benefit of convective clearance by forcing serum out of the body and adding fluid. Okay? And adding fluid. When we write these prescriptions, we write it as a blood flow or blood flow rate. This is referring to how much blood we're taking out of the patient. We write it as an effluent dose. We'll come back to that in a second. We write it as a dialysate flow rate. This is referring to how much dialysate here are we flowing countercurrent against the blood flow rate. And then we also write it as a replacement fluid rate. So this is our pre-filter and post-filter fluid, because we are putting these in our body to replace the fluid that we're taking out of their body. We call them replacement fluids. And so this is going to be your X plus Y. We often separate it as X pre-filter in our prescription and Y post-filter. We'll say X is 300 mLs per hour pre-filter of this fluid. Y is 200 mLs per hour post-filter of this fluid. And the fluids can be the same or different. And then finally, we have what's called the UF rate. This is going to be how much we're doing as ultrafiltration. Now, ultrafiltration is sort of a very important topic that we also understand. And I kind of want to come back to it in a second, actually, after we discuss some of these other topics really quickly that I have on my list that I want to talk about. So, we see so far right now that I have these three things are things that I want to really quickly talk about. So, effluent is really important. Effluent is often referred to as the dose of our prescription that we're actually giving. And why is that? CRRT is different than just regular old intermittent hemodialysis, so not all these principles necessarily fit with what we're going to talk about intermittent hemodialysis, but you're not using that as much, and so I don't want you to think about it. Instead, what I want you to think about is in the blood, we usually have a blood concentration of a solute that we're trying to remove. Let's just use urea because it's a small uncharged molecule that really easily diffuses across. So we have a BUN1 when we remove blood coming out of the patient's body. On the flip side, the urea starting at the beginning of dialysate, right, the urea is going to be 0 in the fluid that we have countercurrent. However, when we dialysate finally leaves the circuit, okay, we call that effluent. This dialysate is going to have a new concentration, uh, dialysate, or let's use effluent urea nitrogen, that's now something else. It's not 0 anymore, right? And it depends. It depends on how fast our blood flow rate is compared to our dialysate flow rate. So for example, if I have blood moving very, very slowly across this membrane, and I have dialysate moving also very, very slowly across this membrane at the same speeds, okay? They will eventually equilibrate where, say, the BUN is 100 here, and then the effluent is 0 in the beginning. But as they move across, these molecules are moving across this membrane, and the concentration is increasing here and decreasing at the top. So this might become 95, 90, 80, and so forth. But as it decreases and the dialysate urea is increasing, we see that there's now less and less of a gradient. And so the rate at which the molecule is moving across this membrane is decreasing over time. And so how do we get how do we sort of optimize this so that we remove as much of the fluid as possible, solute as possible? Well, the way we do this is we try to focus on, sorry for that. So the way we do this is we try to create a ratio of blood flow to dialysate flow such that we are achieving maximal clearance always. How do we do that? We make the blood flow very, very fast in comparison to the dialysate flow. And there's a ratio that we have to be aware of as nephrologists that you don't really have to care about, but as long as we hit this ratio, the blood that we're constantly entering the machine is going to be like at near the serum level of blood. So it will be 100, and by the time it's moved over, only a little bit's been removed from this because this blood is moving so fast that it's always constantly supplying fresh blood with high concentration of urea. Whereas the dialysate is just sitting here in the filter a little bit more slowly, and so that it soaks up as much urea as possible, and ultimately the dialysate goes from 0 to matching what's on the blood side, in this case 100. Okay, so what do I mean by that? What I mean by that is if BUN1 is the blood urea nitrogen, if my ratio is adequate enough such that my blood is much faster than my dialysate flow rate, by the time my dialysate leaves the filter, EUNX that we said is the supposed amount of urea inside the dialysate should equal BUN1. Okay, BUN1 should equal EUN should equal BUN1. That's only if we make sure that our dialysate is moving fast enough. Okay, so let's go back to this. Now, this would only be true if we didn't do what's called pre-filter fluid. When we add pre-filter fluid into a patient's blood flow, we dilute their blood. And so now BUN2 here is going to be less than BUN1. But as long as this rate is still much faster than the dialysate flow rate, then EUNX will equal approximately BUN2. Okay, but this is just a small caveat that I want us to know, that when we use pre-filter fluid, we do dilute the BUN and make it a little less efficient. That's not important for you to know. We do our best to make it negligible, but the key point is that we ultimately do remove most of the BUN. It's just not as much as what theoretically should be assumed. Now, if EUN X is equal to BUN2, what we can say is that the equation of clearance, which is UV over P, where U is generally referring to urine, but in this case, we're actually referring to the volume removed of effluent, right? So EUN. Oops, sorry, messed that up here. So EUN over BUN, so the blood urea nitrogen, times the volume, and in this case the volume is going to be our effluent from the CRRT machine. And if I say that EUN equals BUN as long as I'm achieving my appropriate ratio, right, then this is going to equal 1. So my clearance is now just my total effluent. Hopefully that makes sense. If not, might need to rewind here. But again, what I'm saying is that the dialysate flow has an EUN that should match the blood urea nitrogen as long as the dialysate flow is slower than the blood flow rate by a certain ratio. And so therefore, my UV over P, my concentration of a molecule, in this case urea, in the effluent, or the thing that's being removed, versus the urea in the plasma or blood, should be equal to each other. Therefore, this ratio is just 1, and so clearance just equals my effluent. So that's why we refer to our effluent as our dose. That's why effluent equals our dose, because as long as we're achieving these appropriate ratios, the amount that's traveling through the circuit is our dose. Now, obviously, the dose is limited by blood flow, because if we make the dose too high, the dialysate rate too high, then EUN no longer equals BUN and is only a fraction of BUN, and so we get less bang for our buck. Okay, but essentially when you're reading an RRT prescription, what you care about is the effluent dose here, because that is how aggressive we are being with removal. And we generally standardize this to a patient's body weight. And so a normal starting dose is somewhere between 20 and 35 mLs per kilogram per hour. But we go much higher than that. I've done, 80, 90, 100 mLs per kilogram per hour in some really sick patients. But the idea is, as we standardize to the body weight, and that's our effluent. Now, dialysate flow rate, I told you, has to be within a certain ratio, and so this is going to be star number 2. We sort of already hit this point, but dialysate flow rate is generally going to be X mLs per hour, and our blood flow rate is actually in mLs per minute. So our mLs per minute, so our blood flow rate is actually a lot faster than our dialysate flow rate, because we talk about mLs per minute as opposed to mLs per hour with our dialysate flow rate. Now, our replacement filter fluids are going to be what we talked about here, the amount that we enter in the body, the amount we enter outside of the body, post-filter. And then it's matched by how much is automatically removed by the machine, okay? So I'm going to erase quite a bit of this really quickly to talk about the final part, which is ultrafiltrate. That's that last portion that's starred right there. And hopefully this is making sense. But let's talk about ultrafiltrate really quickly. So my dialysate flow, and then we talked about ultrafiltrate. So ultrafiltrate's anything that is moved across this membrane through transmembrane pressure, okay? And so we've already talked about one type of ultrafiltrate, and that's the ultrafiltrate that makes up for the pre-filter and post-filter. Ultrafiltrate is ultimately going to be the pre-filter fluid plus the post-filter fluid plus our fluid removal rate, FRR, fluid removal rate. This is what the nurse sets, okay? Now, the nurse does not do anything about the pre-filter, post-filter. The machine would automatically remove anything that is already entered in via pre-filter and post-filter without the nurse doing anything. The nurse has zero control over that. So if I add 500 cc's to the patient per hour, the machine is automatically removing 500 cc's. But it's very important we understand that it's still ultrafiltration. It's achieving some amount of convective clearance. On the flip side, the fluid removal rate is what the nurse is setting. This is the amount of fluid they say is going to be removed in addition by the machine. So for example, let's say they set this rate to 100 mLs for this hour. Now they actually have to go in and set this every hour, which is one of the reasons why CRRT is so time intensive for a nurse. But say they set it to 100 mLs per hour for this next hour, well, that is still not our net amount because this doesn't take into account the fact that the nurse, through a peripheral IV or the third port in a trialysis catheter, is giving IV antibiotics, is giving pressors, is giving XYZ and fluids, right? So maybe the patient is receiving 75 mLs per hour for that single hour. And therefore, their net, if the nurse sets the fluid removal at 100 mLs per hour, and is receiving 75 mLs per hour, the net might be 25 mLs for that single hour. Okay, so that's really important. That's why when a nephrologist sets the UF rate, we generally set it as what is the net UF that we want for that hour, and that might be anywhere from 0 to 300. If we achieve net 0, that means we're net. We also call that as net even for the hour. That means whatever the nurse instills in the patient, the nurse has to set as the fluid removal for that hour. So if they instill 150 1 hour because they're getting their vanc that hour, but the next hour they're only getting 25 because it's just the pressors or something, then the nurse has to actively change the fluid removal to match what's going in, and then that achieves net even. On the flip side, if they want net negative 100 for that hour, they have to, and they're adding 150 1 hour, they have to remove 250 for that hour through the machine. But the total UF is going to be that fluid removal that they've set plus the pre and post filter. And this would be the total that we're achieving with convective clearance. And that's just something for us to understand, because when we tell a nurse how much to pull for that hour, it's really important we use this terminology net UF. For example, if you tell a nurse to pull 0 for the hour, set the fluid removal rate at 0 versus pull net 0 for the hour. Those are two very different things. So for example, let's imagine that we're pulling 0 for that hour. So the nurse sets the fluid removal rate at 0, but the patient received 150 mLs per hour for that hour, then they're net positive 150. Whereas if you say, please achieve net 0, the nurse will set the fluid removal at 150 for that hour, and then the patient has received 150 for that hour, so now the patient is 0. In one case, the patient is positive 150. The other case, the patient is 0 for that hour, okay? So that's why it's really critical that we use the correct terminology when we ask the nurse to adjust anything on the CRRT machine. If you're not sure, I strongly recommend you just let nephrology handle it. You just tell nephrology what your goal is and let nephrology do it. Because if the terminology is confusing you, it may actually hurt the patient significantly when you give a direction that's different than what your goal is actually trying to achieve. And so, but if you understand this concept here, fluid removal does not equal net UF for the hour, then you'll be fine. But again, we can make someone net positive by pulling 0, or we can make a person net even by pulling exactly how much they receive per hour. Okay, so that's what we set UF as, and generally I'll say, target a net UF of 0 to 100 as long as norepinephrine and vasopressin are within certain parameters or something like that. It's kind of how I go for it. Okay. All right. So I think we've talked about a lot here. I think if this is all you wanted to know about CRRT, you could probably stop the video here, but I wanted to briefly talk about a few case scenarios that I think are really important for us to understand, so you understand why you might use CVVHDF, convective clearance versus diffusive clearance, and some of the complications that we frequently see on CRRT, so that you might know how to troubleshoot. Okay, so let's assume we have the scenario where we just have a patient who has developed an acute kidney injury, and their urine output is, say, like 10 mLs per hour, and you're calling nephrology saying, hey, they look like they're getting oliguric, maybe even anuric in the coming day. When do we start renal replacement therapy? It turns out there's actually multiple studies that look at different optimal timing of renal replacement therapy, and I'm just going to write a few of them down here. So there's maybe 4 big ones that we should probably be aware of as critical care physicians. It's the ELAINE trial, the AKIKI 2, and START AKI trial. Now, 3 of these trials sort of match with each other, and the 4th one is sort of an outlier. It's the ELAINE trial. ELAINE trial is the smallest trial. It was in a surgical cohort, and ultimately what it says is that starting RRT early is beneficial. Patients are more likely to come off RRT and more likely to do better. The ELAINE trial, again, was in a surgical population. It was the smallest of all the studies, and this study was heavily criticized by the fact that one of the criteria for starting RRT early was a creatinine greater than 2.5, and that's it. Creatinine greater than 2.5. And so most likely patients were put on dialysis, quote unquote, early for someone who traditionally wouldn't be put on dialysis. And so that's probably why they saw more renal recovery in the early start group versus the late start group, they waited a little bit longer before they actually started CRRT. Now, AKIKI 2 and START AKI instead said that if a patient had an acute kidney injury, we can either start within the first 48 hours as if they achieve like a creatinine that's I believe 2 or 1.5 times greater than it was before, versus we actually wait until their K is above a certain amount. I believe it was 6 for one of the trials and maybe 6.5 for another one. Their bicarb is at a certain level, and a few other parameters. Now, the early versus late start is only a very small difference, 1 to 3 day difference between starting for acute kidney injury, but ultimately they saw no difference in mortality or renal outcomes in the groups. Though at 90 days, it's possible that at 90 days, patients who got started earlier were more likely to be on renal replacement later, suggesting maybe there's a relationship between doing more dialysis and less renal recovery. There was also another thing that they saw, which was that patients who were started on dialysis early were probably about 17% of them were probably never going to need dialysis to begin with. So the downside of starting dialysis early is that perhaps we put patients who didn't otherwise need dialysis on dialysis. Perhaps there's less renal recovery later on by doing dialysis. Now, there's a few trials that sort of support this that are separate from these trials. One is the Liberated trial that recently came out in NEJM maybe like a year ago. Another one is a trial that looked at isolated ultrafiltration heart failure patients. Both these trials seem to show that renal function worsens, or maybe there's less renal recovery the more dialysis we do. I'm just going to write these trials out if you're curious to look them up. So the one in the heart failure population was CRRT-HF, and then the other one was Liberated. And ultimately, I think nephrologists sort of argue between early versus late start. There's probably not much difference, especially in ICU population. But my personal opinion is if I have the time, I have the luxury of time, it's early in the day, I'm not waiting for the night shift to start. Um, or I got plenty of time before night shift is going and I can reassess a patient a few times. I'm the type of person who probably will try and wait to start dialysis because it's not going to change outcomes, most likely. Um, but if things are getting sketchy, we're really busy, maybe uh, the the it's the time is getting very close to night shift and I just don't want to bother a night shift person, I'm more likely to just go ahead and get it started at that point, knowing that perhaps there's maybe some damage to there's a theoretical risk to renal function that is been purported, but maybe it doesn't have the strongest evidence saying it. So just something to think about, that we shouldn't always jump to dialysis, and really these studies don't show that there's a benefit except in the Lane trial, which was the smallest and possibly the worst done of all the studies. Okay, so that's scenario one, is when do we start RRT? Now, I think the standard patient that we're going to start RRT on is a patient who just needs clearance. So we're just trying to remove BUN and we're trying to remove potassium. In the standard patient, CVV-HDF and every variation, CVHD and CVHF, are probably very close to equivalent. I mean, I think CVHDF is considered the optimal one, but many facilities don't actually have CVHDF and are forced to do CVHD. But whatever you have is probably going to be not going to significantly change your outcome as long as you get them started on this. If all you want is clearance of these small molecules, diffusive clearance is all you need, and so CVHD or CVHDF is fine without the filtration, the convective clearance component. So that's scenario two, is your standard patient. Scenario three is your patient where you actually want convective clearance. So let's go back to some of our principles about convective clearance. This idea that as ultrafiltrate moves across this membrane, it drags along solutes with it. Now, small molecules easily diffuse across, but middle and larger molecules do not diffuse across this membrane so well. And so this is where you might want convective clearance, because convective clearance forcibly drags these larger molecules across the membrane, whereas they may not diffuse very well. An example of this is myoglobulin. So we often come across these patients who have severe rhabdomyolysis and acute kidney injury. And it turns out that probably dialyzing these patients does not really improve their renal outcomes, but we often get into these situations where, okay, they need dialysis anyways because their kidneys failed, there's no signs of them waking up, and they're going to die if we don't start clearance. And so we start renal replacement therapy, and one strategy that I don't think is wrong, and honestly, if you are already in this situation, why not try it, is this situation where we try convective clearance primarily in order to try and remove these molecules from the body. Now, myoglobulin has a sieving coefficient of 1/5, and so if we just did standard dialysis, it's not going to very easily be removed, and so we can use convective clearance to sort of forcibly remove the myoglobulin from the body. And how we might do this is just increase and crank up our pre-filter and post-filter fluids. For example, I might use 1500 and whatever I want. Post-filter can be as high as I want, as long as I'm not hitting some complications which a nephrologist would honestly handle by themselves. But I could really crank up this pre-filter and post-filter fluid, so I'm forcing 2500 of removal across in order to stay net even. And the idea being here that this is a way of getting around just diffusive clearance, is just forcing the membrane to push fluid across and then us replacing with fluid that is lacking myoglobin, right? So this is how we might achieve convective clearance for certain molecules. Now, for certain intoxications, ingestions, we actually want convective clearance as well. We're not going to get into that, but again, the idea here is that you understand that when you want diffusive clearance, because it's a small uncharged or small charged molecule, then all you need is regular old standard hemodialysis, hemodialysis version of CRRT. But say you want convective clearance because it's a larger molecule that you're trying to remove, um, then you might want to ask for more convective clearance. Okay. Now, scenario 4 is maybe one that um, we see quite a bit, and that's the pH that's incredibly low. Almost there, just two more scenarios. So scenario 4 is, say you have a patient whose pH is like 6.9 and you want started on CRRT. Well, you frequently will ask nephrology for post-filter bicarbonate. Post-filter bicarbonate is just this idea that of our replacement fluids, we're going to place isotonic bicarbonate or hypertonic bicarbonate or some form of bicarbonate as our post-filter fluid. So this could be, for example, 150 milliequivalents per liter of sodium bicarbonate, and this is isotonic bicarbonate. And what we're essentially doing is a peripheral bicarbonate infusion through this, and then the machine automatically removes that fluid from the body so that we don't make the patient net positive, but we're giving them bicarbonate. Okay, this is something that we frequently see, and I think there are situations that do call for post-filter bicarbonate, but I think it's, my personal opinion, so this is me here talking a little bit more ad lib, is that my personal opinion is that we overuse post-filter bicarbonate, and here's why. So it turns out that in our dialysate, most formulations of dialysate, at least that we use, have a 32 milliequivalents or millimoles per liter of bicarbonate concentration. So let's say we have a pH of 6.9 with a metabolic acidosis. Well, these patients usually have like a bicarb of like single digits, right? So now there's a gradient of 8 to 32 in the blood versus dialysate space, right? And so for every liter of dialysate or effluent that we remove, we're effectively trying to drag this bicarbonate from 8 to 32. We're removing 24 milliequivalents of bicarbonate per liter of effluent of dialysate that we run across this membrane. If this is just going across diffusing back across the membrane into the blood, right? Because diffusion goes both ways across the concentration gradient. And so 24 per liter. But now let's say I set my effluent dose really high. I set it at like 5,000 or 5 liters per hour, right? Well, then I'm giving this patient just 5 times 24 of bicarbonate per hour, or 120 milliequivalents of bicarb an hour. That's somewhere between 2 and 3 amps of bicarbonate an hour. Now, if I do post-filter bicarbonate, okay, at a nice decent rate, I am going to increase this by maybe like 50%, and maybe even 100% if I use a really aggressive dose. So I will give bicarbonate faster, but I need us to understand that we do give a lot of bicarbonate with just regular old dialysis alone, okay? And now you're asking, okay, but what's the big deal? Like if we're giving bicarbonate either way, it shouldn't be a problem. So why do we fight ever about using post-filter bicarbonate? Maybe the nephrologist doesn't fight, and it's just me that you'll run across, and I say, hey, I really don't want to use post-filter bicarbonate. Well, I told you that most of the time when we use our fluids, they're balanced fluids. There is a certain amount of calcium, for example, 2.5 to 3.5 milliequivalents of calcium, milliequivalents per liter of calcium in it. And when I do isotonic bicarbonate, okay, this is just the bicarb alone. And there is no calcium in this. Okay, frequently in these patients with a pH of 6.9, your concern is you want to fix the acidemia because they're on 3 pressors. Well, it turns out calcium is incredibly important for your blood pressure as well. And when you give fluid at a high rate that has no calcium, right? So I'm removing serum that has calcium in it whenever the machine is pushing fluid across, a serum that just contains whatever's in the serum. And I'm giving a fluid that has no calcium in it. right? And in addition to that, I'm fixing, what does acidosis do to calcium? Acidemia makes ICal higher, right? Protons bind the albumin, release your ionized calcium. So when I fix the acidemia and we start to develop we give them an alkalosis, right? Well, then my iCal is going to drop. So not only am I giving fluid with 0 calcium and removing calcium, also decreasing the ionized calcium by fixing the acidemia. And this can theoretically make shock worse. And that's probably the reason why bicarbonate has never really been proven to improve mortality, is probably one of the mechanisms. There's a few other mechanisms such as paradoxical intracellular acidosis or CNS acidosis that could probably affect and worsen things. There's this idea that when we have acidemia, we unleash a barrage of enzymes that are meant to protect the body. When we fix that and blunt that effect, then we're not the body's going to stop certain enzymatic process that may be defensive to the body. These are things that we're avoiding, that we can't fix with medications alone, for example. These are things that we need to consider. And so, post-filtered bicarb is probably useful in certain scenarios, but in other situations, we really should be more careful about using this. And so my opinion on CRRT is, as long as my pH is greater than 7.2, I'm just going to do regular old CRRT without post-filtered bicarbonate. I don't think we need a pH of 7.4. Now, if the work of breathing on the ventilator is crazy and we're trying to avoid barotrauma, that's a different situation. Tell us, let's work on it. But even in ARDS guidelines, pH greater than 7.2 is probably good enough. You're not going to see significantly reduced cardiac contractility. More importantly, even when we fix the pH, we don't see an improvement in cardiac contractility and vasoplegia. And so it's just important that maybe we try not necessarily to fix the number, but that's probably that's scenario 4 that I wanted to talk about. Now, scenario 5, this is the last one. Scenario 5 is clotting. This is something that I think we do get involved in, and this is the idea that when we run blood through this filter has these micropores that you can see here. And it turns out blood will eventually start to clot these filters. When blood clots these filters, you lose the filter. And sometimes there can be these larger clots that happen. And if the larger clot happens, then we don't return the blood back to the patient because we don't want to return the clot back to the patient. And so they lose the blood. Now, the circuit roughly runs about 300 mLs in the entire circuit. So that's 300 mLs of blood. So every time a filter clots, they could potentially lose roughly a little over a unit of blood or unit of blood. Filter clotting is the enemy. It really should be considered something that's dangerous to the patient, because if you lose a unit of blood, well, the patient is not going to get better, it's only going to get sicker, right? So it's really important that we focus on clotting and understand why clotting might happen. Now, sometimes it's an issue with the filter itself. Sometimes it's an issue where we actually need to do anticoagulation, of which our options are heparin drip systemically, citrate locally, and then finally heparin locally. Now, at our institution, we don't have protocols for heparin locally, so this is something that we can't do. This would be putting heparin into the circuit here and then putting protamine sulfate here so that it's only anticoagulated in the circuit, but by the time the blood is back to the patient, there's nothing. Heparin drip obviously is going to systemically anticoagulate the patient and help reduce clotting in the circuit as it gets here. And citrate is essentially the heparin locally, where we add a pre-filter citrate to bind calcium. This prevents the coagulation cascade from occurring in the membrane, and then we give a calcium chloride drip through a central line in order to make up for the calcium that we've bound while it was here, so the patient doesn't just suddenly become hypocalcemic and vasoplegic. The nephrologist really should be handling the citrate, And if we ever need systemic anticoagulation, we would ask because citrate might not be working, or we're experiencing what's called citrate toxicity. That's something that I think a nephrologist can explain. But I would say the one time where I want us to be aware is sometimes it actually has to do with the catheter positioning. And so the catheter, when it's inside the patient's body and there are these ports, right? Sometimes a clot can just form here on the outside of the ports and prevent good blood flow in and out of these ports. When that happens, the machine will start to do what's called you start to see pressures in the access, meaning the the pressure to suck blood increases or becomes overly negative. So the negative pressure used to suck blood is going to increase. So the pressure significantly decreases or becomes overly negative, and it's working really hard to suck blood. That might be because a clot is blocking the port. On the flip side, you can get return pressures that are really high, which is where when the blood is entering back into the body, it's having a hard time exiting because of the clot. And so if it's exiting, then this whole area starts to, having trouble exiting, this whole area starts to have more stasis, and that clots the filter. If the access pressure is overly negative, well, then the machine is going to constantly shut off. And so the blood flow is sluggish through the circuit, and so there's again stasis and clotting in the circuit. But anticoagulation doesn't help this because the problem is outside the circuit, and this is a situation where the patient might just need a new catheter. And so it's really important that you're aware that sometimes the issue is not what nephrology is capable of handling, but actually that the patient needs a new catheter. In general, to avoid this issue, I would say right IJs are goal site, our goal site. But FEMs are acceptable as long as they're 25 centimeters. And the thing that we want to avoid for a dialysis catheter is the left IJ, because the anatomic positioning of the catheter as it bends multiple times is more prone to kinks in the catheter as well as clots forming because of stasis as the catheter, because of the sluggish blood flow and the changing directions of blood flow. And so we often get more problems in catheter related dysfunction of the CRRT because of this that limits clearance. So I think this is everything that I wanted to talk about. In summary, I think we talked about the definition of clearance in order to understand why and how we dose CRRT and why it's effluent based. We talked about diffusive and convective clearance, and then talked about some situations where you might use one over the other. And then we also talked about ultrafiltration and how it's calculated and how we can communicate with a nurse in order to determine how much we're trying to remove. Okay, thank you.